Thank you all for joining us. My name is Moita Chargo and I'm a research analyst for GSMA's Mobile for Development mHealth team. I will be moderating today's webinar, How to Maximize the Impact of mHealth Services for Maternal and Child Health. If any questions, please use the control panel on the right and we will try to address them at the end. Progress in maternal and child survival has been made. However, this has not been enough to achieve the Millennium Development Goals 4 and 5. Despite recent improvements in MDG 4, almost 3 million of all the babies who die each year can be saved with low-tech, low-cost care. This forms the basis of the UN Commission on Life-Saving Commodities. Similar in MDG 5, even though maternal mortality has declined dramatically, the situation is still worrying, specifically in sub-Saharan Africa, where an African woman's risk of dying from pregnancy-related causes is 100 times higher than that of a woman in a developed country. mHealth is starting to deliver on its promise of health system support, but can isolated examples of impact at scale be fast-tracked to deliver on the MDG goals in 2 years' time? Using existing success stories, we will try today to explore 4 key drivers of successful and impactful mHealth services: reducing fragmentation, delivering scale, replication across other disease portfolios and countries, and alignment of the value proposition for health and mobile. Let me introduce today distinguished speakers joining from Nairobi, Cairo, New York, and Cape Town. Judy Nyogo is a product manager for e-health and e-learning at Safaricom, one of the leading mobile network operators in East Africa and the home of M-Pesa. George Health is a VP of Commerce at Islam. George pioneered the mobile baby mHealth service that won the Mobile World Congress Awards Best in mHealth Innovation and Best in mWomen Awards in 2012. Alice Lynn Fabiano is a Senior Program Officer and Advisor to Johnson & Johnson Corporate Contributions. In this capacity, Alice leads philanthropic strategy and programming for mHealth. Joanne Stevens is a consultant for Mama South Africa, better known as the Mobile Alliance for Maternal Action. Mama recently won the 2012 Fast Company Magazine Service Design Award. Thank you all for joining me. If we're going straight into our discussion, Judy, I hope I still have you on the line. Judy? We know that there is an incredible amount of fragmentation happening across the world and that this is limiting the impact of mobile on the health system.
Yes.
Judy, of the 700,
yes.
Great. Judy, of the 700 mHealth services that the GSMA reviewed, 37 were in Kenya and 9 focused on MDG 4 and 5. Safaricom is currently involved in 8 mHealth services and is about to launch a new maternal and child mHealth service. Can you explain how you, as a mobile operator, have engaged development industries and government to support existing health interventions and through mobile?
Hello?
Judy?
Sorry. Yeah, sorry, I didn't hear. For some reason, you went blank, as though you were muted, so I didn't hear what you said, sorry.
So the question is regarding the fragmentation and how about the new maternal and child mHealth services that you are about to be launched. And maybe can you explain us how, as a mobile operator, you have engaged development industries and government to support existing health interventions and leverage efforts through mobile?
Okay, thanks, Marta. Well, it's true there's a lot of fragmentation, hence a word that has been used a lot in the mHealth space called pilotitis. We have all these little fragments all over, all kinds of pilots that are going on that cannot scale. So as Safaricom, what we have done is we have realized that we are just a technology, an enabler. So we have worked with different development and government partners to make sure that we are able to enable them achieve what they do best. So I'll give an example. There's a product that we call KimChip, which is a maternal, newborn, and child health information platform. And we have been able to partner with 3 development partners, specifically World Vision, CARE, AMREF, and NetHope. The World Vision Care and AMREF are actually NGOs that are currently on the ground that do a lot of implementation of government projects on the ground. And then NetHope, we work with them specifically to ensure that there is interoperability and to make sure the standards are there. But above all those, we have had to work very closely with the government because we realize that we really cannot achieve scale unless we are working on what really the government wants to do. We are aligned with the government's vision. And specifically, we have had to work very closely with the Director for Public Health and the different departments, the Department of Family Health, Department for Reproductive Health, Department for e-health, and we have been integrated into their various working groups. Then that way, whatever we are doing actually has the ownership of the government, and that way it ensures scale, it ensures that even after the NGOs have pulled out or maybe there's no funding anymore, the government actually runs with it. So it's been endorsed by the government. So that's what we found at Safaricom that we need to do to make sure that we remove the issue of fragmentation and we ensure scale and sustainability.
Great. Thank you very much, Judy. George, Mobile Baby was one of the first mHealth services in Nigeria. Judy has mentioned development partners and government engagement as a critical factor for reducing fragmentation. Can you give us a Etisalat view on partnership development and working with government? George? Maybe moving from George to Jan. I hope, Jan, we have you on the call on the other side.
Yes, you do. Hi there.
Hi. So, Joanna, from Mama's perspective, Mama efforts in Bangladesh and more recently South Africa seem to be gaining traction. Can you give our listeners a sense of how Mama is collaborating with local and international public and private partners to avoid duplication and fragmentation of services?
Yes, sure, absolutely.
Thank you.
So MAMA stands for the Mobile Alliance for Maternal Actions. So by its very name, it's all about collaboration. And in fact, within MAMA itself, there's already a very clear structure of both international and local partnership. For those that don't know, MAMA at the global level has 5 key players: USAID, Johnson & Johnson, Baby Center, the UN Foundation, and the Secretariat, the mHealth Alliance. And then in the country implementations in Bangladesh and in South Africa, this structure is actually echoed through the formation of local consortia that engage regularly with global. Now, if I move to the South African situation specifically, the MAMA consortium here consists of 3 organizations that really complement each other with varying strengths across tech development, content development, community outreach, monitoring and evaluation, etc. And together they're much better equipped to deliver an effective service than any of them would have been to do it alone. But even if you look just across these 3 players, each of them is engaged in a number of other independent mHealth projects or research studies, which has resulted in quite a fragmented field. So what we think one of the positive outcomes of the MAMA consortium has been is that by gaining experience and trust, by working together, they're now starting to drive towards an increasing alignment between some of these services, making sure that the content, technology, branding is consistent. So to give you an example, Cell Life, which is one of the MAMA South Africa implementers, was building an independent SMS service for mothers called SMS Baby, and that has now been rebranded to MAMA to be brought under the MAMA umbrella in an effort to reduce duplication. We've also found that it becomes much easier to engage with government and to request their endorsement when this coordination work is done internally. Then by the time we actually go to them, we can present a coherent and consistent message and identity rather than a number of disparate projects. It's also easier to apply for funding as an experienced consortium and, of course, to engage with mobile operators. And then at the same time as this internal work is being done, there's also engagement with other organizations. So, for example, those working on different but related work, such as mobile messaging to fathers or mobile messaging to midwives, or those that have been helping with content review and testing. such as Mothers to Mothers or the Clinton Health Access Initiative. And in this way, we're ensuring that there's a lot of internal consistency. Thanks, Moitza.
Great, thank you very much, Joanne. And I think we have George on the line now.
Yes, you do. Hopefully you can hear me now. In Etisalat, we're looking a little bit from the different perspective on the mobile health. We clearly, from our positioning, looking at this as a business proposition, not a CSR aspect. And this drives entire positioning and entire implementation of the service. So we strongly believe that only by building business sustainable ecosystem where all members of the community are actually making money out of transactions or out of all the activities, that actually drives sustainability and scale of the projects. Obviously, we work together with the government, and very interesting, many very different agencies in the government, not only with the ministries of health, but also with the central banks, for example, to ensure sustainability of the business. And this drives the aspect that all members of the ecosystem, from the midwives to the medical practitioners, to the doctors, to the NGOs and insurance company, actually making money out of the transactions. And this drives the business to be scalable, extendable, and sustainable across multiple territories. So this is what we believe is the key proposition, making money out of this one, of the mobile health, versus building as a good feel CSR opportunity for organizations.
Okay. So George, you briefly already mentioned the scale, and I don't know, one of the hot topics actually being discussed in 2012 is the scale itself. Looking at the mobile development intelligence website, mobile money services have demonstrated scale in a number of countries. And the Etisalat Mobile Baby Initiative, as already previously mentioned, won this mHealth Award for various innovative solutions. And as you already briefly mentioned, you also successfully launched mobile money services in Nigeria. Could you maybe elaborate more in how has the integration of mobile money into the mobile baby service enabled Etisalat to scale across your markets?
We believe that mobile money is a foundation and the main driver to make a business aspects of the service. So when the same midwife who is providing services to the future mother at the point of care is able to get paid directly into her mobile phone and use this mobile this creates a sustainable business platform for her to be able to execute the service. So if the mobile money is a foundation on which we're putting lots of different verticals, if you can think about it, it's a layered cake. The foundation for this layered cake is mobile money, mobile health, mobile education, mobile identity. So all of those activities are layers on the cake, and which makes the proposition much more scalable and sustainable across multiple territories. And our numbers talk by themselves, because right now we have mobile money in 12 countries.
I'm sorry, George, the line is dropping a little bit. So the last that we heard is that now you have mobile money in 12 countries. George, do we still have you on the line? It seems that the call dropped. Let's move to Alice. Alice, I hope we have you on the line. Dialing in from New York, I would think that there shouldn't be a problem.
Yes, I'm here.
Great, perfect, thank you. So Alice, from a funding perspective, we kind of moved from discussing the first topic of fragmentation into discussing the second topic with George already on scalability. And from the funding perspective, is there a shift in funding appetite away from smaller proof of concept projects to multi-party initiatives involving public and private sector stakeholders? And can we expect funders to start investing into initiatives that deliver integrated health, education, money and other functionalities?
Thanks, Morita. I'd say that stepping back from the mHealth funding environment and more broadly into philanthropy, there is this age-old argument of whether the way and the philosophy of funding is letting 1,000 flower bloom, or whether or not what you're hearing a little bit more often now on taking big strategic bets and backing a couple of horses in the race. And so that argument, I would say, is alive and very active right now, and you have a lot of new philanthropic foundations really coming in towards the big bet area, and that is changing the conversation. What I'll say is, diving a bit deeper into the mHealth funding community, you'll see as well the conversation has shifted. I would say the funding and the dollars allocation has lagged behind the shift in the conversation. So there is still, I'd say, a need to move more towards bigger, scalable solutions than to proof of concept. That being said, I think it really does also depend a bit on where we are in the spectrum for various projects and evidence base within there. mHealth is an innovation in and of itself, and innovation requires some time and some proof of concept in order to really emerge into one of these evidence-based interventions. And so I would caution against having no proof of concept or small investments in new ideas. I think they're very valuable. The other trend that's happening right now within the funding universe, as many of you know, is around public-private partnerships and shared value. The concept of, and these two things are different, but public-private partnerships of, moving from each foundation investing in a silo and in its own intervention to forming public-private partnerships such as MAMA, as Joanne spoke about, where you do have public entities like the U.S. government and the UN and private sector corporations like Johnson & Johnson coming together with a shared goal and the hope that that will drive the needle further, faster, and bigger in terms of outcomes going forward. The other trend that is happening now is around shared value or double bottom line, and you did hear George speak a little bit about this. And if you're engaging corporates, and I sit on the foundation side, but if you're engaging corporates from a business and emerging market, new portfolio perspective, there is a need for both a profit-making element as well as a public health outcome element in order for shared value to work. And you can underlie that with an environmental element as well. And that is a new and unproven concept. We've seen some interesting pieces in particularly recidivism in the UK, as well as some of the work out in California with green initiatives, which are taking the lead on this. But this is another trend, and I think mHealth has the opportunity to be one of the success stories in making shared value work.
Great. Thank you very much, Alice. George, I believe we have you on the line.
Yes, I'm back. Thank you.
So the last thing that we heard before you dropped down was that you're involved in 12 mobile money services. Could you maybe?
Yes, right now.
Yeah.
Yes, right now we're in 12 mobile money services, and our rollout of mobile health and mobile education is following up very closely with mobile money. So as soon as the foundation for the service mobile money is in place, we're immediately moving forward with other implementation of the services. And this actually drives to another aspect which we strongly believe in, it is a lot, is makes the services acceptable on the market. And this is ability for operations to actually go on the ground, roll your sleeves, and execute. Because it is very easy to sit in the ivory tower office and speak about how important the services are and how we can do it to the people. But what we believe what's very important is actually going on the ground, roll your sleeves. Right now I'm in the remote area of Egypt, and that's why the line is really poor, and actually do the stuff on the ground. And this, from our perspective, really drives adaptation, defragmentation, and the scale of the services. Just do it.
Okay. Thank you very much, George. Judy, we don't need to reiterate the incredible success of M-Pesa. I know that Safaricom are considering leveraging the payment platform in a number of ways. Can you maybe explain how you see the vertical integration of mobile money, health, education, and other areas driving adoption amongst your customers?
Yeah, thanks, Moita. I think I can start by giving just one very interesting statistic for us, for anyone who doesn't know about M-Pesa. Just recently, the central bank released some statistics, and one exciting one was the fact that Kenya right now we have achieved 80% financial inclusion. But the sad thing is when you remove M-Pesa from the equation, it goes down to 23%. So that means M-Pesa and really using the mobile phone to access some of these initiatives, whether it's in health or financial services or education, is a must on this part of the world. So how we see the vertical integration into health and education, actually we've been applying it a lot. I'll give an example in education. We have a product that we call the Lipa Karo. That's Swahili for pay your school fees. So what happens is each school has what we call a pay bill account, and parents or whoever is sponsoring the students can actually just pay directly without going to the place, or the people who are unbanked can actually just send money directly to the school, and it's very secure and it's taking on very well. So that's one way that we're seeing M-Pesa working as far as education is concerned. Another example of the value that we're getting from M-Pesa is in health. And for that we have e-vouchers, because in many of the remote areas, in the bottom of the pyramid, we have development partners and government sending money to people who are in very remote areas, maybe to go to hospital, if it's for antenatal care visits for the mothers, or any of those things that is really a requirement for them to go to a facility and they don't have money to pay for that. So we're using M-Pesa to do that. We also are working very closely with the government. I'll give an example of a solution that we're doing for TB, tuberculosis. What happens is the government has field workers that usually have to go to many places, and they've been sending money using paper model, but then now we have successfully moved them to being able to transfer the funds using M-Pesa, meaning the money gets to the people in real time, and reporting is also done in real time. So we've been able to achieve efficiencies as far as that is concerned in health, and as well as in micro health insurance. Many people may not be able to access health insurance if they have to go somewhere to buy it, because most of the insurance companies are within the very urban areas like Nairobi, but the rest of the country doesn't have it. Trying to send out payments, receive payments is very inconveniencing, but we realize that when people can make their premium contributions via M-Pesa, and any payouts are made via M-Pesa, it's working perfectly for us. I'll give an example for why M-Pesa was able to take up very fast, and why it's being we're able to use it, like George said, as the basic layer on which we're able to layer on services. In Kenya, we have about 40,000 agents, M-Pesa agents. When you compare that to the total banking combined agents of about 2,500, it means that on every corner, really, you have an M-Pesa agent, so people feel that they are secure with their money. It doesn't have to stay in the house, because on every corner I can actually just go and withdraw the money and use it for whatever I want to use it for. So the fact that M-Pesa is already there and it's working very, very well nationwide has made it easier for us to be able to roll out health and education and even agriculture services.
Great, thank you very much, Judy. Reducing fragmentation and supporting scale are two key drivers to the successful integration of mobile into health. Equally as important are being able to synthesize the best practices for application and alignment of the value proposition between mobile and health stakeholders. Alice, I hope we still have you on the line. I would just like to ask you, what is J&J looking for in existing maternal, newborn, and child health services as a benchmark or best practice for further investment and replication of services to other countries?
It's a really good question. You know, I think that there are two things, and part of this is staging the process. We know that we are in a field that's untested. We know that we are in a field of innovation. And while there's a lot of stories around the magic of mHealth and the magic of mobile in general, I do think and would caution that in the health industry, both on the business and on the philanthropic side, it is not an easy sell. And part of it is that it's very, very new, and a lot of folks think of mobile as a luxury rather than a essential thread to how to do their work, and that takes time. And so what I'll say from both a replication and scale perspective, before you even get to those two pieces, we need to prove that it works, and we need to continue to build the evidence around interventions working, both from a story and a qualitative perspective, but also from a quantitative perspective. And I think there are different ways to measure that impact. Certainly for me, a lot of evaluations are both expensive and timely. And so, you know, oftentimes you don't get the results so far past when you need them, but there are new ways to really measure innovation, and so from a continuous perspective, to know whether or not you're on track or directionally in the right direction to make that next investment. I think once you get comfortable with that it is working in these small test cases, whether it be one country or one disease state, then we can start talking about scaling and replicating across countries and portfolios. For me, there's a couple of things that we look at. Probably the one I'll highlight for this group is return on investment, and that's a metric in which you look at something. You say, for the dollar that I spent in investing in mHealth, you know, what is the alternative, and is it a better bang for my buck, for lack of a better term? And I think it is, but again, I think it's something which still remains to be seen. And that really means, you know, if you are implementing a program that is supposed to improve the health metrics of delivery for mothers, you know, you better be able to back it up from a perspective of, yes, this is more effective than sending out the midwife and having that delivery happen through investing in training more midwives. And that's the comparison right now that is happening within the health and health philanthropy space and within Johnson & Johnson Foundation. I think beyond that, then, scale and replicability can happen in one of two ways, and it's really a choice of how you see it working best. The analogy that I'll use is whether or not you want to go to a buffet or whether or not you want to go to a prix-fixe dinner. Right, and with the buffet, when you're thinking about scaling and replicating, probably as you look at people going to a buffet, 20% of their food on their plate's the same, and 80% is different. Right, everyone gets, you know, the bread and the steak and, you know, maybe the salad, and that's about it. And then the difference is the rest of 80%. Somebody may get the crab legs, and someone may get the mashed potatoes, and someone may get the ice cream. So it's kind of a 20-80 split, where 20% is the same and 80% is different. It's much more of a modularized approach, and so you see folks like UNICEF with Project Moana and the replication they've done across their large organization happening this way, where it's much more of a buffet style, and you pick and choose what you want to eat amongst a group of portfolios, and the way that they've crafted it is across a 1,000-day nutrition cycle. And so Nigeria may decide they want to start with PMTCT and not do antenatal care. Zambia may decide they want to start with nutrition and zinc and ORS messages. and linking supply chains there. But that is the way in which UNICEF has chosen kind of a more of a buffet style. The other alternative is what I would call a prefix menu, which is where it's 80% the same and 20% different. And folks like a Baby Center, which is a Johnson & Johnson business, is closer to this model, where you look at the content that they're delivering to pregnant women across the world, and 80% of it's about the same. Every woman wants to understand what's going on with her body. Every woman's going to need to know what are the warning signs for distress in the baby. What are the ways, what does cord care mean? What does skin-to-skin mean? Things like that will stay the same, and 20% changes based on the cultural elements in there. Same with their technology. Same with the approach of being stage-based in every country and sending relatively the same number of messages, no matter where in the world you really are in. So those are two kind of ways to think about replicating, and whether or not you modularize it or whether or not you do an end-to-end solution. And I think there's a lot of debate right now of which one is the right approach to go.
Great. Thank you very much, Alice. George, listening to Alice, what are the key drivers that Etisalat is looking for to replicate the mobile baby services?
See, for us, the position is much easier, because as we operate across 18 countries, for us, setting up the best practice and experience in 1 or 2 countries, and after this, using what we call cookie cutter approach to replicate it across other markets, obviously to take into account specifics of each local market, specific of the cultural and in some aspects even business aspects, but still having implemented in a couple of places, making sure that it's all working, and after this fast rollout across multiple territories for us enables the service to be really easy, expandable across multiple markets. Saying this, I really like to stress that lots of very much country-specific aspects, cultural aspects of obviously implementation of services in Tanzania and Afghanistan is very different purely from the cultural perspective related to the countries, but still addresses the same needs, the same positioning, the same requirements from the regulatory perspective across the markets. Using cookie cutter approach actually enables us to sustain fast rollout of the services across multiple territories.
Great, thank you very much. Moving to the last key driver, to the alignment of the health and mobile value proposition. GSMA is working currently with the WHO to understand the health and mobile value proposition. ROIs, market share, outputs, and brand loyalty are very different value drivers to the more traditional clinical outcomes, access, and cost drivers for the health industry. Joanne, you talked earlier about the government and mobile operator engagement. How are non-governmental organizations like MAMA thinking about incentivizing the mobile and private sector for long-term investment?
Thanks, Moita. I'd say that first and foremost, NGOs like the MAMA Consortia in South Africa and Bangladesh can assist operators and other corporate partners by taking on responsibility for content development and review, because this is not typically an area of expertise for the private sector partners. And so the NGOs can ensure that the content is evidence-based, locally relevant, has been expert reviewed, is compliant with any government regulations, and of course, whenever possible, has actually been endorsed by the government, so that then the operators can confidently partner, knowing that they don't need to do this kind of intensive vetting of content themselves, which could expose themselves to risks, since this is not their area of expertise. Then mobile services like MAMA can be a real draw card for new users, because the content is very accessible, it's targeted, and it's locally relevant. So particularly where operators are trying to encourage users to try something new, where they might be unconvinced of the value up front. So for example, in South Africa, the askmama.mobi site is a way to encourage users to try data services if they haven't done so before. And it can also be a useful example for cell phone retailers who are trying to demonstrate the kinds of value that a mobile phone can offer. So they can show that if you purchase this phone, MAMA is the kind of service that you can now utilize. This kind of content is also very sticky, and so it brings users back because it's dynamic and it evolves with the mother as she progresses through her pregnancy. So very good for customer retention and brand loyalty. PreCult Foundation, which is the leader of the Mama South Africa Consortium, they've had a very similar experience with a related platform that they run called Young Africa Live, which has been hosted by Vodacom on their operator deck called Vodacom Live, and has also been zero rated for users, meaning that it's free of charge for users to use. And because Young Africa Live is an engaging community platform, it's very sticky, it's actually the most popular area of Vodacom Live, and it brings those users back, and then they can also be introduced to other Vodacom services. This high-quality content can also be exchanged with other popular Mobi sites as a form of in-kind marketing to drive traffic to the service. So Mama South Africa could contribute small samples of the content for free, and then in exchange they'd likely gain some new users. So that's another example of a really good win-win, but with the emphasis being on the content, the NGO actually maintaining that high-quality content. Then next, moving on from that, I would say NGOs can also add value by putting in the work to build a strong and engaged user base on mobile through their community outreach, moderated discussions on Mobi, and so on. And this is the kind of work that some of the operators and corporate partners don't really have the time or expertise to do. This then becomes very attractive for advertisers who are targeting the same demographic if they wish to tap into a very loyal and active community. And it also provides incentives for co-branding and marketing with other organizations. So just to give you an example, Mama South Africa is in discussion with organizations that are using some other media channels, such as TV and radio. And if the TV or radio show discusses a maternal or child health issue, the audience can then be encouraged to continue the conversation on the mobile platform askmama.mobi, where there's now an opportunity for further community strengthening. So both brands are strengthened by that partnership. And of course then, as a longer-term goal, by generating this active and engaged user base, starting with the high-quality content, the service can then be a lead-in to other mHealth services focused more on service delivery, such as things like medication ordering, appointment booking, purchasing of health insurance, the microinsurance that Judy was mentioning earlier. And these kinds of services are often very commercially interesting to mobile operators and also to other corporate players such as pharmacy groups, medical insurance groups, and so forth. Thanks, Moita.
Great, thank you, Joanne. Judy, any responses on how best NGOs, civil society, and health organizations should be engaging with mobile and private sector?
Yeah, thanks, Moita. I think one thing that I remember Alice mentioned public-private partnership framework, and we are finding increasingly that when we are engaged as a partnership, where it's a public work and a public, I'm also putting in the development partners with the private sector, that those kinds of partnerships will work. Because I'll give an example, really not even really as an example. When you think about what Safaricom or any other mobile provider would be giving, we are not the experts in health or if it's education or whoever, we are just enablers. So when we have partnerships that work, such as the PPP, then that would be a very good framework for engaging the mobile service providers and private sectors in general. Another thing that I'd like to raise is, unfortunately, a lot of times when we engage with the NGOs and civil society, usually they come with the mindset that the telecommunication service provider should actually also donate their services. And yes, maybe we could donate our services, but it's not sustainable. So we find that when we engage in business models that make money for the private sector or for the mobile provider, then that becomes sustainable. The private sector or the mobile service provider is expected to come up with a business model that, yes, makes some money for them and ensures that the service is sustained. I keep drawing back to the example of M-Pesa because it's something that we have learned from, and we're drawing a lot of our learnings from there as we scale into other verticals. And initially when M-Pesa was created, it was created mainly as a stickiness product. We did not think it was going to make that much money for us. We just wanted people to think Safaricom is nice and they should stick with us. And what happened is right now actually it's one of our most profitable brands, and it's being scaled right now through Vodafone, as many of you are aware. So at the same time, on the private sector, it's very important for us to realize that much as we are measured on ARPUs and all that, it actually builds brand loyalty, and at the end of the day, you're able to keep your larger subscriber base and are able to roll out more services that make sure that your ARPUs go up. Thanks, Walter.
George, would you like to expand maybe or give any additional thoughts on the similar question?
Yes, maybe only two really small points. One is obviously it's an ecosystem game, so all of us have expertise and knowledge and experience only in a certain aspects. So from this perspective, everybody needs to be a part of the big ecosystem and ensuring that everybody works together, because none of us, would it be NGO, medical practitioners, insurance company, governments, ministries of health, able to pull it on their own, because the opportunity is huge, expertise is very targeted and very centralized. So from this perspective, by working together as a part of the ecosystem, we can only make the business sustainable and scalable. And another thing which we didn't touch today at all, and which I believe is extremely important, is we, as MNOs, we need to work together on this one. This is not, mobile health is not what we can compete with each other. We can compete on the GSM calls, on SMSs, data tariffs, kind of normal services. But mobile health is such a transformational service where we can actually give back to society that we cannot really compete with each other. We can really work together. And to me, the role which comes from the government, from the GSMA, from other players of the ecosystem is making sure that all telcos are working together, and at the end of the day, customer is not discriminated that based on the fact that his SIM card is green color or red color or orange color. He just needs to have access to the service and be able to benefit from all aspects of the proposition.
Great, thank you very much, George. Alice, can you maybe also expand on any insight into what you see as a shared value proposition? And do funders have the ultimate role in defining these shared value drivers or impact indicators before implementing a project?
You know, I just want to, I want to recognize George's last comment, because it is a really, it's a really hard thing to say, I think, and I really want to applaud George for saying that. I think we all, from the private sector side, have competition from competition from the business lines, and it is not an insignificant feat to step over that line and hold hands in a partnership around health outcomes, and I think it's a good role model to set for him and then for the ecosystem. So I did want to recognize that comment. I'll just add 2 points to shared value and alignment, because I think the panelists really covered this really well. One is, we should, in a public-private partnership, in this work, we should recognize that all the stakeholders, whether we be funders, organizations, public sector, government, medical practitioners, we do need to first and foremost be the stewards of moms in maternal health. And that needs to be the fundamental piece that links everyone together. And this is a very tenuous place where I think trust is not yet formed yet around whether or not the best interest of the moms is always at the heart of everything we do. And we want to guard and protect that kind of fragile piece of it. I'll reference the microfinance sector, who has battled this and hopefully is coming out on the right side. But you see where the balance around profit and public health has, for some, really gone off keel. And the SKS IPO out of India has caused a lot of discussion within that universe. And Vikram has recently come out, who sold SKS and IPO'd it and made millions of dollars, has recently come out and talked about the imbalance that has happened there, and really the ripple effect within India and microfinance has had due to this kind of rebalancing that needs to happen between profit making and serving those most in need, and protecting and being stewards of the poor. And so we as the mHealth community have an opportunity to learn from that and to move forward from it. I think microfinance is decades ahead of where mHealth is. You speak with some of the early folks in that space, and it's been 30 years to get to a place of scale, replicability, and profit-making pieces. mHealth can take that 30 years of learning, take and glean the best practices, and be really strong stewards of the public. That leads me to my second point, which really is, it took microfinance 30 years to get to a place of profitability, scalability, and double bottom line success stories. So we are really in an emerging place right now. And the other thing I want to make sure folks are really realistic about is really a timeline for exit. So this is really not a place I would think anyone would want to invest to make a quick buck. I don't think it's any place where anyone want to invest to save a mother's life quite quickly. I think both from a health and a profit perspective, we are looking at much longer timelines than a 1-year or a 2-year exit opportunity for either of those two pieces of a shared value proposition. And it is one where the benefits on the other side and the rainbow at the end is so worth the journey through it, but we are very much at the early part of the journey. And this shared value concept and what we can achieve through mHealth, both from an ecosystem, health, and a profit perspective, is one where people are watching us closely, and we can really make it work if we work together.
Great, thank you very much, Alice. I would now like to open questions up to our online audience, and while we do that, just to reiterate the key messages from the discussion. Reducing fragmentation requires partnership development and strong engagement and support from government. Supporting scale is key to driving a critical adoption of customers. There are a number of best practices emerging that can help companies and organizations replicate in shortened time periods. And lastly, the issue of a shared value proposition needs to be driven by all stakeholders early in the planning phase of any project. Today we cover 4 main key drivers: reducing fragmentation, delivering scale, replication across other disease portfolios and countries, and alignment of the value proposition for health and mobile. We received various questions from our audience, one of them being, how significant role tariff plays behind uptake of mHealth and mLearning services? For example, do you think a service with less tariff will enable more uptake? How can we provide mHealth services for maternal and child health services for free or at low tariff? Thank you very much, Danny, for sending this question through. I will actually like to first ask or hear what is the opinion from Judith and George's side. So maybe, Judy, if you go ahead, and after George, you can elaborate on the question.
Okay. Would you please ask the questions again? I heard something about education and.
Okay. So it's how significant role play tariffs behind uptake of mHealth and mLearning services? For example, do you think a service with less tariff will enable more uptake?
Okay. We are finding that of course, and the tariff cannot be ridiculously high for some of these services. We are finding that most of the people that would take advantage of mobile learning or mobile health are, for the most part, the bottom of the pyramid, and for them, the price is very sensitive. So yes, tariffs play a major role, but at the same time, even the consistency of the service matters, because you could have maybe some services in Kenya. Some of our partners, our competitors are even providing voice at zero. So I mean, so you really, they're not charging for any services, but then it's what else you're able to add to it. Yes, the price matters, but then at the same time, the value that you give matters. So for a mobile provider, for a lot of these services, you want to have smaller margins, but then enjoy scale.
Could you also elaborate on how is government taking the role in, for example, maternal, newborn, and child health initiatives?
Okay. The government's role actually is in owning the services. I'll give an example. In Kenya, most of the healthcare, really they say about 95, but it's more between 60 and 95, is run by public sector or missions. So they end up working very closely with the government. So anything that anyone would want to introduce in the public sector needs to have that endorsement of the government. Not only do we need them for endorsement, we also need them to create an environment. So come up with a policy framework to be able to support some of these initiatives.
Great, thank you. George, could you maybe share with us your opinion?
Yes. At first, this concept of layer cake for us is key important aspect. Mobile education, it's a very important layer, and it's great that you touched this one. And in a couple of schools in Nigeria, we already started with educating people on how to actually, at schools, how to use money, what's the right way of using money, how to save money, what's the purpose of this one. And this actually drives, this layer of the cake actually helps to drive all other services. One thing what Judy was saying is absolutely right. You cannot offer the service for free, not just because it's not a sustainable business, but because the value you bring into the service, if it's given something for free, it means it's no value. At least this is the perception what market has. Service doesn't have to be paid maybe for the end user, maybe it doesn't have to be paid by the pregnant mother herself, or some NGO, governments, insurance companies in some cases are paying for the service. But the value perceived for the service should be associated with the price which somebody is paying for this one. Because at the end of the day, even at the bottom of the pyramids, you don't want to put your hands and your health of your future child into something which is for free. It's just not properly associated, not from brand perspective, not from the quality of service which you're trying to deliver to the consumer.
Great, thank you very much, George. Joanne, it's going to be interesting to hear your opinion about it from an NGO perspective.
Yeah, I would say that our experience in South Africa. Hi, can you hear me now?
Yes, perfect.
Moita? Oh, great, super. I just had to unmute. So I was interested to hear what George was saying, because our experience in South Africa has started to deviate from that a little, in that our mobile market now is reasonably mature. We have very high mobile penetration here and have had at the level of about 95%. And people have been paying for value-added services for quite some time, and have in fact in some cases been quite burned by those services, especially early on, where things were at times very expensive and the prices were not necessarily transparent. And so there's actually now an enormous reluctance to pay from the consumer. So I think that the point made about how others may be covering that cost, NGOs, funders, health insurance companies, etc., is a good one. But the ability to actually transfer that cost to the end user is quite limited, because it really does affect uptake. So we find that our users, will pay the standard network rates for things, although certainly uptake is much better when things are zero rated if it makes sense for the operator for whatever reason. But when there's an additional cost placed on top of that, it really does limit our uptake in South Africa, and that's just based on the experience of our implementing partners here.
Great, thank you very much, Joanne. And I think that's also why the market research itself is so important, and what George actually previously already mentioned. What would be also interesting to hear is from Alice's perspective, and what would be the donor support to kind of subsidizing the tariffs for maternal, newborn, and child health initiatives. Alice?
Sure. From the kind of private donor perspective, I think we take into account that there is a role for us to play. There are also roles for others to play, and it goes to this question of who pays at the end. You heard a perspective from Joanne, at least in South Africa, that the user herself may not be the right one to pay. We've heard other instances, and I think it varies by country, that may or may not affect uptake, and that's to George's point of value of the service, and do people value it more if they're paying for it. Certainly the research from the malaria bed net perspective shows that paying an affordable price for a bed net has people value and using that bed net more often than if you give it to for free. We've seen that on the opposite side for other pieces, such as health itself, and I think that's fundamentally from a health information and a health learning perspective. Broad-based saying, I think there's a belief that it is a public good and hence it shouldn't be paid for. So I think it's a fair argument either way. I think for the private donor perspective, you know, we are a drop in the bucket in terms of the dollars and money needed and spent globally around maternal health. And the role in which we tend to play and want to play is a catalytic role in innovation, where it may be too soon for businesses to invest from a profit perspective and make that case, or it may be too soon for government to come in and say, yes, I'm going to take the allocation out of training nurses and put it into a mobile service piece of the work. Certainly the private sector and the foundation world can play a role in supporting innovation and making the case so that further down the road, I think where you're really going to get scale and sustainability and the dollars to be able to pay for that will be very much in the government or in the business sector. It will not be in kind of a foundation role. What we can do is catalyze it.
Perfect. Thank you very much, Alice. As always, we have a few hours worth of questions and conversations still rolling in. Nevertheless, unfortunately, our time is up. Alice, Judy, Joanne, and George, thank you very much to join me from all the 4 amazing cities. Very appreciate thank you from myself, the GSMA, and big thank you to our audience for your insight into how mobile can be leveraged to support MDG 4 and 5. For our audience, thank you for your time. For more information and resources, please visit mobiledevelopmentintelligence.com and gsma.com Mobile for Development mHealth, where you will be able to find webinar recording and slides. You can also follow us on GSMA M4D, and please do send me emails on mhealth@gsma.org if you have any questions. Thank you very much and have a great time.
Thank you.